Welcome to session 4. We are talking today about a very important topic that is really fundamental to implementation science, which is the determinants of implementation. We have 2 all-star implementation science methodologists who have graciously volunteered to lead today's session. We have Allison Carroll, who is a health psychologist, and Amy Van Pelt, who's a global health scholar, and both are implementation science superstars. Amy's actually joining us from Ethiopia, where she's doing global health work in implementation science. So it is late for her, and we're especially grateful that she could be here with us today. And we are going to spotlight both of them because they will be kind of tag teaming throughout the slides today. You're in for a real treat, and I will turn it over to Allison and Amy.
Thanks, Sarah. I am excited to be here because implementation determinants are one of my favorite parts of implementation science, so would not miss it despite being in Ethiopia. And thrilled to be here with Allison. I think this is our 3rd year in a row that we've given this lecture together. So next slide, please. We'll start by giving an overview of implementation determinants, high level, and then we'll dive deep into one of the very common implementation determinants framework called CFR, the Consolidated Framework for Implementation Research. We'll then center health equity within implementation determinants and end with our case example, our running case example, and our breakout discussion. So what learning objectives are we hoping to achieve today? By the end of today's session, we hope that you all will be able to describe context, identify appropriate conceptual models for determinants, and really highlight the importance of incorporating perspectives from different groups for understanding implementation context.
Thanks so much, Amy, for our introduction. Oh, sorry. So getting into what are the determinants. The determinants, when we're thinking about this in terms of implementation, is we want to understand what works, where it works, and why it works. We want to know why the intervention or program or innovation that we are trying to implement works or tends to fail, but also why the implementation strategies that we will be developing and talking about more in the next session, why do those work or fail given the context that we are implementing in. Our determinants can either be on the positive or the negative side. So when it's positive, it's something that makes implementation easier, and we call that a facilitator. If it's negative, that is something that makes implementation more difficult, and those are our barriers. So determinants, barriers, and facilitators are equivalent here. And one thing that was really helpful for me when I was learning about this is thinking about what a determinant is. We use the term social determinants of health all the time. And the idea is that, for example, socioeconomic status. If we think about folks with high socioeconomic status, they are more determined to have better health outcomes. And so that's a positive, that's a facilitator, having high socioeconomic status for health. Whereas if we go to on the other direction, we think of it being a barrier, having low socioeconomic status, as it makes it more difficult to access healthcare. You're more likely to have poor health outcomes. So hopefully that's a helpful tidbit when we're thinking about determinants of implementation as well. The determinants may also act as moderators or mediators of implementation, and evaluating implementation determinants and assessing the context is often used to guide formative evaluation for implementation. So putting this into the context of what we've seen in some of the prior lectures, we're down here towards the bottom where the implementation determinants are really the conditions that make it more difficult or easier to actually do the thing. Again, our barriers and our facilitators. And you can think about it in using this beautiful graphic that Amy put together. mHealth and mobile applications are all the rage these days. We do so much really cool user-centered design. We build these beautiful platforms. We think about the best way that we're going to get them out to folks and get them to engage. We gamify the system. But then if you try to take that to an environment where smartphones just aren't very prevalent, either in the population or they don't have the network infrastructure to support smartphones, well, the mobile application is not going to go anywhere. It's not going to do anything to help anybody in that setting. So we really have to be thinking about the context in order to consider whether our innovation is going to be able to get out there and do the thing that we hope it's going to do. If we think about where determinants fit on the subway, it's one of the first things that we start to think about once we get into that green area where we can do our mixed methods approaches to understand the context. It also really serves as the basis, as you can see from where it sits on the implementation research logic model, that it's formative. It's something that lays the basis for all of the implementation study that you're going to be doing thereon. And thinking about it in terms of theories, models, and frameworks, we are really trying to understand or explain the influences of our implementation outcomes. And there's a whole section of determinants frameworks. And even more so, from 2019, there was already a scoping review that found 17 determinants frameworks. That was 5 years ago. If this were updated, this could easily be doubled by now. And so because you'll get the slides, just wanted to share a couple of really common determinants, models, theories, and frameworks. These are all clickable links that you'll be able to access. And what we're going to do today, what Amy's going to take over, is doing a deep dive on one of the most common ones. So I will turn it over to you, Amy.
Thanks, Allison. So I think this was previewed in the theories, models, and frameworks lecture, but one of the most popular frameworks for understanding context is called CIFR, or the Consolidated Framework for Implementation Research. Thanks. So you can just click through all of them as I speak, Allison. So essentially, CIFR is a framework for the systematic evaluation of factors across multiple ecological levels. And I believe that you all read the updated CIFR for class today, but we wanted to just explain the original framework because a lot of the published literature to date may have used that original model. So it's important to understand what you're looking at and that there are differences out there. But essentially, CIFR is a meta-theoretical model, meaning that it was developed by synthesizing prior theories, models, and frameworks. And this is really helpful because one of its strengths, I think, is that it's quite comprehensive. It consists of 5 domains and a lot of constructs that I'll walk us through in detail on the next couple of slides. But I also want to highlight there are some limitations with this framework, and I believe the state of the field in implementation science in general. But it's that we don't really have a way to understand the relationships or the interactions between these constructs and these frameworks. And this last point here, before we dive into the details of the framework, want to highlight that given that CIFR is so comprehensive, we want to emphasize that it's important to select specific constructs that are most relevant to your study. And it's important to not try to use everything in that framework for your one project. So again, just highlighting the different versions of CIFR. So first, CIFR 1.0, or the original CIFR, it has been widely used in a lot of studies, specifically over 375 studies in this one review across different implementation contexts. And it's helpful for explaining implementation determinants or explaining our findings. For example, what are the barriers or facilitators to implementation with regard to those different domains? But a couple of years ago, there was an update to CIFR, or CIFR 2.0, some of us call it, which was updated for a couple of reasons. So this model, it increased applicability because it replaced the term intervention to innovation, which made it more comprehensive in referring to the thing that's being implemented. It also specifies or increases the specificity of actors. So they replaced patients with recipients to refer to individuals that were intended to benefit from the innovation. And they also added the concept of deliverers to specify who was going to be involved in delivering the innovation. There were also a couple of modifications that involved adding constructs to include important themes that I believe were missing from the original version, such as local attitudes, meaning sociocultural values and beliefs. And just want to highlight that although there are these differences, the published framework, still has 5 domains with the additional 48 constructs and 19 subconstructs. So here is CIFR 2.0. As I mentioned, it consists of 5 domains, including outer setting, inner setting, innovation, individuals, and the implementation process. And thanks. We'll walk through each of these, starting with the outer setting. So the outer setting refers to external factors that affect implementation, like government policies, financing, community values, community beliefs. The inner setting refers to internal factors that affect implementation, such as clinic structure, relative priorities, available resources. So to give an example there, say you're implementing an intervention or your thing into a school, the school would be your inner setting context here. The innovation simply refers to components of your thing. So its complexity, its design, its cost, its adaptability, etc. Individuals refers to factors that are related to the people involved in implementation. So those may be factors such as self-efficacy. And again, I want to highlight that you can have both deliverers, so people who implement the thing, such as your providers or your community health workers, as well as recipients, so people who use the thing or receive the thing, like patients. And finally, implementation process refers to how to implement the thing. And folks, myself included, often conceptualize this domain as your implementation strategies, which you'll hear in greater detail, I believe, by Allison in the next session. Okay, great. So we know CFIR, but one of the most common questions that I get in implementation science consults is how and when do we actually use these frameworks? How and when do I actually use CFIR? So before I answer the how and when, I want to just make sure that we're on the same page in what we're talking about here. So I often suggest to people that they go and do contextual inquiry, or you may have read in a paper that a team did contextual inquiry. And what this simply means is that they're asking about the context to understand the determinants. So when do we do contextual inquiry? And feel free to click through all of those. My answer to that is it depends, which is a very implementation science as well as epidemiology answer. But it truly depends because you can first do pre-implementation contextual inquiry where you're asking about determinants before you implement the thing, which is helpful for better informing your strategies. But on the other hand, you can ask about factors after implementation or post-implementation contextual inquiry. And when you're deciding when to do this process or when to do contextual inquiry, it's important to consider whether or not your intervention or your thing actually exists in the setting or already exists in the setting, and what would be most helpful for informing your strategy selection and your tailoring to context. So how do you do this contextual inquiry? You know what your framework is now, but what do you actually do? So you can use qualitative research methods like semi-structured interviews. You can use quantitative methods like surveys. You can also consider mixed methods, which I think is pretty cool, where you can do some qualitative work to identify implementation determinants. And then you could put those determinants into a survey and have your constituents or various folks rank the strength of those implementation determinants, for example. But regardless, for any of these approaches, it's really important that you're considering who your constituents are or who you're asking about these implementation determinants. Those could be folks like your providers, your Ministry of Health, given the work that I do, your community health workers, et cetera. And that also you're informing your data collection instruments by a determinants framework such as CFIR. So I'm going to pass back over to Allison to talk about how we can really center health equity in our evaluation of implementation determinants.
Thanks, Amy. So yes, as you heard, there have been pushes to figure out how to better integrate health equity, especially thinking about the implementation context. Not always the most successful. So what we're going to talk about today are some examples of what's been attempted, and we recognize that there's more work to be done in this area. So we know that historically the determinants frameworks have been limited because a lot of them tend to be content specific. So CFIR used to be pretty specific to healthcare settings. They have tried to broaden that, like calling it instead of an intervention and innovation, instead of patients and recipients, right? But there's still been, there's been some discussion of local attitudes that are trying to capture that sociopolitical climate, but it still hasn't fully tapped in a way that really captures the health equity that I think a lot of our work is trying to achieve. There also isn't a great understanding of the mechanisms of determinants. Again, Amy mentioned that CIFR and many of the other determinants frameworks do not really show relationships between the determinants themselves. Like there's some work that this has become a burgeoning area in the field, trying to better understand the mechanisms of how and why things work. And so the determinants frameworks that we have, they're a great starting point, but we also don't want you to feel too limited or constrained by what exists. Some ways to try to address these limitations is really to include all potential partners' perspectives in that contextual inquiry that Amy was discussing, where we want to think about all levels of people who could potentially be affected by the innovation, by the thing. Also, all who could potentially have an effect on the implementation of the innovation or the thing. We want to include all these different perspectives in how we, any frameworks, models, or theories that are developed, and also any implementation plans that are developed, because those folks on the ground who are affecting or affected by, like, they're the ones whose perspectives and opinions really matter in what's going to actually get done and what the outcomes are going to look like. Another limitation has been that our terminology tends to be all over the place. Implementation science being a newer field attracted folks from different fields, and they're all coming together, but they are still like hanging on to some of their old terminologies, creating new ones in different models and frameworks that we're like, oh, these two things look the same, and yet we're talking at cross paths here. And so much of that is just a terminology problem. So there has been some push to work on making some of that terminology more consistent. And in this takeaway from a paper that Amy and Renad wrote is that greater generalizability on the concept of context of the setting will enable better communication and collaboration. So again, goes back to our takeaway that context is key for implementation. We did want to share one example of a framework that has probably the most common one that I see and hear about that has tried to integrate health equity into a determinants framework is the health equity implementation framework, right there in the title. This was developed by combining IPARIS, which is one of the implementation determinants frameworks that we shared on the previous slide, with the healthcare disparities framework. And so already you can kind of hear that that is pretty localized to healthcare settings. And it was trying to explain those factors that result in differences in healthcare for vulnerable populations. And so you can see that in the outer circle, we're thinking about the societal influence, the physical structures, economies, and sociopolitical forces that might be influencing ultimately the clinical encounter and how especially vulnerable populations are receiving healthcare, with the idea that considering those things is not only going to lead to successful implementation, but will also improve health equity. Just checking my notes, making sure I didn't miss anything. So you can hear all of the implementation pieces, understand how they're trying to think about health equity at every point, so that then we're not just having it as an afterthought. It's something that's integrated throughout and is explicitly measured alongside implementation.
Thanks, Allison. And I, given my bias, wanted to include this slide. One, given the audience that we have in our reading course, as well as the fact that I'm currently in Ethiopia conducting implementation research. So as you can probably imagine, there's a really big inequity in the application of implementation science between high-income countries and low and middle-income countries, which then has downstream effects for health equity. So why is this? One of the potential reasons is that a lot of our tools were developed in high-income countries, which, as you can imagine, presents a lot of limitations for the application of those frameworks and resources in LMICs. For example, some of the constructs that are included in CIFR or some of our determinants frameworks are not actually relevant to resource-limited settings. Or on the other side of that coin, there are really important concepts in global health that are missing from our existing frameworks. There are also a lot of accessibility concerns, such as linguistic barriers, because most of our tools are available in English. And I want to highlight this with a framework that hopefully at this point we're all familiar with. There was a systematic review of the use of CIFR in low and middle income countries, which revealed that one, there were constructs that were not compatible in these settings. And then two, they also identified a need to propose a new domain called characteristics of the system that essentially related to things like external funding priorities and resources that are really important considerations for this context. I also just want to emphasize this point here that I think it's important that we're continuing to assess the relevance and the appropriateness of our frameworks. I know we have a lot of them, but we want to make sure they're useful to the work that we're doing, given that has an influence on the ability to pursue implementation research and, again, subsequent influence on health equity if we can't do implementation science in our low and middle income countries. So I'll pass it back over to Allison to highlight one of the case examples.
Okay, so I will go through this briefly to focus on the barriers and facilitators here. But just as a reminder, this is the case example of screening and brief intervention for risky drinkings in pediatric trauma centers. So first, the gap was identified. They selected the thing to be used, and then now we're at this point of assessing the barriers and facilitators. And to build our implementation research logic model, again, we have the screening and brief intervention, evidence-based intervention thing to be implemented. We know what outcomes, effectiveness outcomes we're interested in evaluating, especially patient follow-up with primary care and then reduced drinking. And so what was done next was some of the contextual inquiry that needed to be done. And there you can see the examples here of two publications that were used, qualitative and quantitative methods, to assess what was needed in order to, what were going to be some of the barriers, what were going to be some of the facilitators of implementation. So from this work, we were able to populate the barriers and facilitators on the left-hand side, again, very foundational to what the rest of the implementation plan was going to look like. You'll notice that this is divided up into the CIFR domains, the outer setting, inner setting, individuals, innovation, and process that Amy mentioned earlier. And what you'll also see after each of the bullet points, there is either a plus or a minus or both. That indicates whether this is a barrier or facilitator for implementation. What you'll notice and what is really interesting and very common is that these plus / minus, that's the it depends coming back to haunt us. But so much of this, if you remember, this was done across 10 different sites. And so what this is saying is that if this is present, it might be a facilitator. If this is absent, it might be a barrier, or vice versa, depending on what it is. And so some of this, you might need to take it site by site to really think about, okay, what are implementation strategies that we need to address all of these things? And where might we need to be a little bit more specific, site specific in our planning?
Thanks, Allison. And I want to add to that point, and I see Sarah also just put it in the chat, just to concretize just from something that happened today where we're implementing a mental health intervention and one clinic has a psychiatrist, the other does not. So clearly strategies are going to have to look different there. If you have a provider who can facilitate an intervention, so that's a facilitator, but in the other site, that provider does not exist, so that therefore is a barrier. So it really depends on the site and the context in which you're implementing your thing. But to wrap us up, before we break out into our discussion groups, we want to just reiterate the key takeaways. So first, implementation determinants refer to factors that affect or influence implementation. You can have multi-level determinants, so again, across all those ecological levels in CIFR. You can have positive factors such as facilitators or negative factors such as barriers. Also want to highlight that sometimes facilitators can be confusing terminology, given people think about an individual who's facilitating the implementation. So you may also hear that as enablers, so barriers and enablers to implementation. And really the whole point of this discussion and this whole point of this lecture is to emphasize that context is critical for implementation. We did include a couple of additional resources that may be helpful, primarily related to CIFR. So if you all decide CIFR is useful for your work and you want to go in and actually apply it to your study, here's a list of resources that you could examine or could explore further. So we included things like the CIFR website, which has a detailed description of all of the constructs and domains. There are also sample data collection tools, so it can give you an idea for how to actually develop CIFR-informed questions. And a lot of other interesting resources, but want to highlight the CIFR-ERIC matching tool, which you may want to come back to next week or next lecture after we talk about implementation strategies, because it can help you show how you can have implementation determinants and strategies work together. So a couple of additional points before we ask the leadership team if there are any quick announcements. Here are some questions that we posed to the group. So you all in your small breakout sessions may consider when have determinants acted as barriers or facilitators in your own work, even if that has not been implementation research. How have you actually identified implementation determinants in your work? And how would you go about centering health equity in the contextual inquiry process, given all the limitations that we've highlighted? There are also some appendix slides that go into greater detail, which we won't do now, but if you want to look at some of the other implementation determinant frameworks, there are concretized examples. But I'll hand it over to the learning team and see if there are any announcements before we break out.
Thank you so much to Amy and Allison. I'm amazed how much you packed in to less than 30 minutes. That was an incredibly efficient and thorough coverage of contextual determinants. The only quick announcement, I'm going to put a link in the chat just announcing that new CATS pilot awards, which are awarded annually, are due on the 15th. So if you're like super activated to be seeking funding in the current climate, this is a great opportunity. They plan, I believe, to award 5 pilot grants at about $40,000 each. And if you're not interested in applying for funds, but you are interested in gaining grant reviewing experience, you can also email us because we are compiling a standing study section for that. So feel free to just use CDIS at northwestern.edu if you have any questions about the pilots or if you want to express interest in reviewing. As you can imagine, implementation science is core to translational science, so lots of interest in that topic. All right, so we are going to start to put you all in your breakouts. Thank you all so much, and we will look forward to seeing you again in 2 weeks on the 19th.